Good afternoon, and actually, first of all, many thanks to Lenny, because I really enjoyed these 3 days, and very intensive, but very provocative, and so really thank you very much indeed. Lenny asked me to cover or to present to you, from the pediatric perspective, the European landscape that, of course, would have been almost impossible in 20 minutes. So what I have done, just to pick up some lesson from current European clinical ALL trials, which include adolescents, I have to say with respect to that issue, that in most European countries, with very few exceptions that I will present to you today, the upper age limit of adolescents is 18. So in our trial, we are basically cover only 1/3 of the, let's say, of what yesterday Archie Blyer defined as a 10 years critical transition time from 15 to 25. But if, despite of that limitation, we are facing some problem, and I, of course, will discuss on the other side the data that we have obtained in the fraction between 14, 17, or 15, 18, might be of course, of interest as well to be tested in older young adult. So the 3 experiences I would like to present briefly are the ones from the NOPHO, and the reason being that is the only prospective study, at least to my knowledge in Europe, that bring together, pushed by pediatric field, the pediatric and the adult, of course, treating in different places, up to the age of 45 with the same protocol. And it's very, very interesting. The second experience I would like to present, briefly has been already touched upon this morning by Dr. Fidling, is the data from the UCAL 2003. And finally, briefly, report the experience of the largest consortium in Europe, which cover many countries and lead by the Italian, the German BFM group, which has been working together for more than 20 years by sharing the protocol. And so I'm very pleased to report the most recent findings. I will definitely touch, if we have time, some of the critical issues that are still open. So the first one is, as I said, the NOPHO. The NOPHO is a Northern country pediatric oncology, hematology oncology group, which cover the country that you've seen in this map. And they have launched this study covering the age between 1 to 45. And the accrual seems to run very well. As you have seen, they plan to continue until 2015. The schema, of course, is an open study, and Kjeld Smigelov from the Denmark was kind enough to provide these slides and present it to you. Of course, there are not outcome data, but just to outline the strategy, which would be is currently applied for all children, adolescents, young adults, and adults up to the age of 45. You see, this is just a schema of the 3-drug induction, and then at the day 29, this further stratification is MRD-driven into in standard, in intermediate risk, and high-risk patients. So according to the basically some features of diagnosis, but no according to the age criteria, patients are stratified. And this is just to highlight the different blocks, which is mostly based on the BFM experience as well, with, of course, as you see, an intensive use of asparaginase in the context of this treatment. Just very few clinical features of this cohort, quite interesting because there will be patient enrolled in a prospective study. You see a very well-known phenomenon that by progressive by age, you see a switch in the percentage of cases with the B-cell phenotype as compared to TLL. Not surprising, you see that there is an inverse correlation between age and tumor burden, as you can appreciate by this cartoon, as well as well-known, the white blood cell count in TLL has a completely different figures as compared to older patients. and not surprising at all, by increasing the age. And this is something very important, at least from the pediatric setting, because by including older patients and adolescents, we are facing the problem of having increased percentage of patients with high-risk features, either defined by genetic profile or by MRD response. And not surprising, as you can see, as you compare the 1 to 6 or the 6 to 10, progressively you see an increase in the percentage of the intermediate and high-risk patient as well. So we can draw any conclusion, just to say that it's a very interesting experience running, which clearly highlights that TLL is far more frequent in adolescents and young adults, that tumor burden at diagnosis is inversely related to age, and based on differences in prevalence and TLL, MLA rearrangement, and higher MRD, not surprising. AIA, ALL are more commonly stratified among high-risk group. Another important point, which I believe should be very important in trying to compare and understand the different outcome results by using even different strategy, is that it's very important to compare apple with apple in terms of risk stratification criteria if you really want to make a further improvement in this category of patient. The second experience I want to bring to your attention has been already, as I mentioned before, brought to you by Dr. Fielding this morning, mostly for the issue of asparaginase toxicity. And this is the UCAL 2003, and Dr. Ajavora was kind enough to send me just a few slides in order to highlight a few points. This is a clear one example of where the age, which has been mentioned yesterday to be critical, was considered the age, because patients up to the age of 24 plus are included in this study. And the treatment protocol is basically highlighted, and I do not have time to go into detail, but few points that the patients in the AYA category felt either in the intermediate risk or high risk. And of course, they switched from one to the other, starting from diagnostic criteria based on the MRD response. This is just a schema of the TYA treatment. Is clear, indicating at least in this context, the highly sensitive MRD detection by using IG and TCR approach that we mentioned yesterday is a way by which the patient can move from the intermediate to the high risk. The UCAL 2003 achieved, as Dr. Fielding presented this morning, a remarkable and I would say outstanding results in the 16-plus subgroup with 77% of the overall survival, and as you can see. But if you stratify the patient according to the level of MRD and as assessed by day 29, you see that the high-risk patient, despite of still having a good prognosis, do have a worse outcome as compared to the patient of the same age, of the same risk stratification, when with a different MRD profile. These are basically the risk stratification I've seen already this morning. Again, just to highlight that as a pediatrician, by increasing the age up to even to 18, we have progressively increased the high-risk features of our patient. And the most striking issue, at least from our perspective, it's not that we are not used at all to the progressive increase of toxicity that we are facing in this category. And this has been clearly highlighted this morning by Dr. Fielding, just by seeing that if you put together the death in induction and the death in remission, and this is definitely, at least from any physician, but definitely from our pediatric background, probably the worst experience that you might achieve with. Losing a child or adolescent in complete remission. This is something that we have clearly to think about. We need to try to understand the reason of this failure, the reason of this increased toxicity, and definitely find a better strategy. The last The last experience I want to bring to your attention is the ones I am personally engaged, because our center is coordinating, together with Martin Schrappe from Kiel, the IO-BFM consortium, which is probably the largest consortium in Europe in dealing with acute lymphoblastic leukemia. I'm very pleased to report the data of the closed study and some update of the new study focusing on the difference by age and, again, the question of toxicity. The IOP-BFM 2000 was a fully MRD-based stratification study. Patients were stratified a diagnosis by cytogenetic and the prednisone response at day 8, but later on at 1 month, 3 months, only based on the MRD, patients were eligible, even independent by age, to the different risk subgroup. One important question of the study, which I think is still very well discussed in the lymphoblastic leukemia field, it was the randomized comparison between DEX and PRED and the induction phase. And that was a very important lesson, because despite of a significant difference in the event-free survival between the two arms, in the BCP, we didn't see any difference at all in the survival, because probably you can say is expected, but we didn't know, we knew that would have been a risk of the study. The DEX arm has an increased toxicity, mostly for infections. So the issue again, that in our field, increasing the intensity of the treatment does not translate necessarily to a better outcome. And this is a clear example, but this was in the BCP setting, but by contrast in the TLL, clearly, as you can appreciate, the curve, the upper curve, produce for patient independent by age, treated with DEXA and very intensive treatment, an extraordinary outcome. Today, a patient with a TLL with a good response by MRD has the same prognosis as yesterday Steve Unger presented for the COG study with very similar results. The age has an impact, yes. And if you see the 15-17, clearly there is a difference, and there is a difference for the B lineage. This curve of the T lineage is misleading because it comprises either patient who received DEXA and prednisone at the beginning of the induction treatment. But again, one of the most relevant issues in the age 14-17 is the profile of toxicity and the outcome if you take according to the response to treatment. As I mentioned before, this study was a fully MRD-based for risk stratification, and accordingly, we did have patients with the age 14-17 defined as high risk or non-high risk according to the response. And what was impressed by, and of course by confirming as well the results that the UCAL 2003 produced, is that if you take the high-risk patient, you can appreciate that the 15-17 age as definitely an inferior outcome, which is not the case if you take the age and the non-high-risk profile. Clearly indicating that within this age, you still have a fraction of patients who still have a great challenge to be improved, because this is clearly not an outcome that we like to see. And of course, as already shown by the 2003 in the UCAL study, this study clearly provides evidence that by intensive chemotherapy, at least in the age 14-17, you can achieve outstanding results. One of the questions, of course, does the transplant matter? The indication in this protocol for transplant were very stringent, but when we analyze the data correctly by including the time to transplant as a criteria to compare correctly, as Dr. Fielden said yesterday, the chemotherapy arm and the transplantation didn't show any significant advantage. So if you ask the question, is transplant an option for the 14-17 LL patient with high-risk features? The answer is today no, because apparently we do not see any significant difference. And this, of course, is one of the reasons why we still deserve a different strategy to be considered. As I said before, one of our major concerns, and actually, as you have seen from the UCAL study, is the issue of toxicity. And the toxicity, of course, is striking for patients receiving high-risk treatment burden, which is, in the context of this protocol, mostly given by very intensive blocks. Whether it's an issue of chemotherapy or whether, as I personally believe, we should consider additional issues and additional factors. For example, behavior, compliance to the treatment, we never consider as a variable important, but definitely for this age are probably, when you have a patient with severe neutropenia and you are losing 24 hours for admission because he or she doesn't pay attention to the abdominal pain that might have, these are losing a patient only for the delay in referral, only because there is less attention by the parents and more independence by the adolescents. So toxicity is an important issue, and these are just the Protocol 2009. The only point I want to tell you is that by just modifying the criteria of high-risk patient, and by adding new criteria, which has been the hypodiploidy, the slow response to treatment, and the high response flow at day 15, in that category, 14-17, we double the percentage of patients, suggesting that even in terms of response, this subgroup of patients, according to age, is clearly different. Of course, we cannot make any comparison with the past. I want just to tell you these are 3 years EFS, and as compared to the previous study, it seems to be a trend in improving, despite the fact that, as I said, we did double the percentage of patients enrolled in the study. So let me draw a few conclusions, probably more relevant because these 3 days have been a very heavy discussion, and I don't think we have any problem to define who are the adolescents and young adults. The question is, we are treating differently, even because the definition is different. And I personally strongly believe that what Archie told us yesterday is a crucial issue, independent if you're taking from the perspective of the pediatric setting, where you can treat this patient only up to the age of 18, and then from the adult perspective, you have to take is absolutely mandatory to try to achieve this patient enroll in prospective study. This is the only way to achieve a significant improvement. And let me just, sorry, I did a mistake. The second important issue is we need to learn how to compare apple with apple in order to compare toxicity and outcome. And so, for example, who are the high-risk adolescents and young adults? Is the MRD the only prognostic factor? We heard yesterday from Charles Mulligan that probably this is a category in which the PH-like phenotype are likely to be more prevalent, and accordingly we have a chance to foresee a different strategy. Are different therapeutic regimens currently used similar? And this, you might be surprised, but it's very different to find publication where really match apple with apple in the age of 15, 25, and see what are the variables that can explain either in terms of toxicity and in outcome. And this, at least as my take-home message for this meeting, is absolutely mandatory to be done. How we can handle the death rate in CCR? And again, from my perspective, it's not only a chemotherapeutic issue, is probably more a wider vision on how to approach this age, where, of course, independency, private parents, and the less attention to the minor detail during the course of treatment can make the difference. And finally, how to identify subgroups of young adult ALL eligible to new target therapy. And finally, is there any role for transplantation? Data are very scanty, and I don't think that the registry data will provide the answer to that. We need to have patient enrolled in prospective study, and this is probably my most relevant message. I will skip the conclusion, but definitely I share with you, although it's in Italian, that we do have the same role altogether to break down the key alphabetic letter of a still dreadful disease that I believe we are all working together to face. Thank you very much for your attention.